Okay, chapter 1 is about elimination, and elimination is important. Everybody has to eliminate, but we need to help them with their privacy while they're eliminating. A patient, we talked about this in another chapter, people are more concerned about their physical needs than their safety needs. So if you have a person who needs to go to the restroom, you need to help that person first, because their physical need to get to the restroom is going to cause them to try to get up out of the bed by themselves. They are not going to wait for their safety need of staying in the bed, pressing the call bell, waiting for you to come. They need to go. They need to go in a hurry, and they're going to do everything they can to get up and get to the restroom, even if they fall in the process of trying to get to the restroom. So make sure when you have patients who have elimination needs that you're helping them first. But elimination is the term for ridding our body of urine and stool. We all have to do this. Some of us don't think about it that much, but we need to get up and go to the restroom. Some people more frequently than others. But if you've ever been in a situation where you really had to go and you couldn't get there, you were not waiting on safety needs and waiting for someone to come help you. So elimination is being able to go, and we need everything that comes in has to come out. So being unable to go can keep you from thinking about everything else. It is a very basic need to have to eliminate. So depending on someone else to eliminate can be embarrassing for some people. So we need to make sure we're asking about elimination needs in private. Don't ask in front of their visitors or their guests, or if their roommate is in the room, make sure you pull the privacy curtain and ask them discreetly if they need help to the restroom, if they'd like to go to the restroom. You want to try to toilet them before they go to the shower and encourage them to be on a toileting schedule, kind of like you do when you're potty training. After you've eaten, maybe 30 minutes to an hour after they ate, you want to encourage them to go to the restroom. Before they go to bed, do they need to stop by the restroom before they get into the bed? Discomfort is when our digestive system slows down. Everybody, as we age, the food passes more slowly. A lot of people get constipated. Slower bowel patterns, more constipation. We also get urinary tract infections. People retain urine for some reason from incontinence, or they don't urinate like they should, or they don't wipe like they should, and we're going to start getting more urinary tract infections. Again, always asking in private, talking to your resident in private. If the resident can't tell you, ask the family members, or go by their toileting schedule. Make sure that you are taking them to eat taking them to the toilet after they've had something to eat or drink, taking them before they go to sleep, taking them when they wake up in the morning. Think about your own bowel patterns when you go to the restroom, when you have a bowel movement. Some people have a bowel movement every morning. Some people have a bowel movement every evening. But having a bowel movement means you're defecating. So a bowel movement or a stool is defecating. And then urinating is having urine. Tips for promoting regular elimination patterns: make sure you're helping your residents to the restroom as soon as possible. If you just make sure they're on some kind of schedule or their own schedule, what their preferences are, when they would like to go to the restroom, and getting them help as soon as you know that they need help to the restroom. Responding to your call lights properly, making sure they're eating a balanced diet. You're never supposed to withhold fluids. You can't tell someone, oh, you can't have anything to drink after 8 because I don't want you to wet the bed. If they want to have something to drink or a snack at any time, make sure they're getting plenty of fluids. Residents that have urinary tract infections definitely need a lot of fluid because they need to pass the bacteria out of their kidneys, out of their bladder, and in order to do that, they need to flush it out with plenty of fluid and plenty of urine. They also need to be drinking fluid so they don't get constipated. If we're constipated, then it's going to start causing your stomach to distend. What we talked about in the anatomy chapter. Distending means their stomach is getting larger. They could be distending because their bladder is filling up, or they can be distending because their stool is backing up in their intestines. Make sure your residents are getting enough exercise. Make sure they're getting enough rest. And then making sure that you're always asking those dignity questions in private. Maintain a professional attitude. You're not supposed to use nicknames or unprofessional gestures. You're not supposed to pinch your nose or wear a mask. But you do always need to wear gloves. So whenever you're handling bodily fluids, stool, urine, make sure you have gloves on. If you are going to touch their bedside commode or their bedpan or their urinal, you have to have gloves on before you touch these things. You also need to make sure you're not putting anything that could be possibly contaminated on any of their bedside tables. If you need to, put it on a plastic bag and put it on the chair. But don't set this on a surface that's going to eventually have food on it or something that they touch frequently. So make sure you don't hang their urinals on their side rails. Make sure you hang the urinal on the bed frame or in a urinal holder, or put it in a plastic bag and set it on the ground under their bed. Don't sit it on their bedside table. Same thing with their bedpans or their bedside commodes. Part of privacy is emptying your bedside commode as soon as they use it. It's not a porta potty where it just keep the urine and stool in there. Every time you use it, it's your responsibility to rinse it out and clean it. You rinse out your bedpans, you clean your bedpans, and then you put them back in a trash bag. They're labeled with the patient's name on it, and then you hang it back up in their bathroom or in sole utility according to your policy. If you're wearing gloves, you should be wearing gloves at all times. You can explain to the residents about infection control. It helps protect them. It helps protect you if they ask why you have gloves on. But most of them will never question why you have gloves on. When you're emptying your bedpans and urinals and bedside commodes, flushing them immediately, never pouring your urine or the rinse water down the sink. It all goes into the commode or the toilet and flush it. You can use some odor control sprays if your facility allows, but never let this resident feel like they're burdening you or that you have this gesture or look of disgust because of their stool. Everybody's stool smells. Everybody's urine smells. Now, if their urine smells abnormally foul or fruity or looks funny, we'll talk about that a little bit later, make sure you're reporting that to the nurse immediately. Same thing with their stool. If their stool is black and tarry, it could mean they have a GI bleed. You're going to let us know. If you see bright red blood, they may have hemorrhoids. So be careful when you're wiping because those hemorrhoids are painful. All of these observations are things that the CNAs are responsible for. Some residents are going to be using a bedpan. These residents are still continent, which means they know when they need to eliminate. They know when they need to have a bowel movement. They know when they need to urinate, but for some reason they're on bed rest and they're not allowed to get out of the bed. Maybe they just had hip surgery, but whatever reason, they need to stay in the bed and we need to offer them a bedpan. We never put a brief on a patient, an adult diaper, and tell them, oh, you're covered with a diaper, just go in your diaper. That is a dignity issue. If a resident asks you for a bedpan or asks you to take them to the restroom, even if they have an attends on or brief on, you still have to take them to the restroom or you still need to give them the bedpan. There are two different kinds of bedpans. There's a regular bedpan that's a standard pontoon bedpan that's fairly large. There's the ones we sent home with you in your buckets that you're practicing with. Make sure you are putting your patient on the bedpan. The way that they go on is their bottom goes here, just like they would be sitting on a toilet. Okay, so the curved edge is where their bottom is, and then this raised edge right here is sticking out a little bit in the front so that when they're laying on it, they can urinate and it goes into the bedpan. This is a fracture pan. Again, this area right here is where their bottom is going to be sitting on it. And then it's raised here, it's sticking out a little bit from their legs, and they're able to urinate into the bedpan. Now, women or people with hip fractures or smaller people or children are going to use the smaller fracture pans because they don't have to move as far up off the bed to get it underneath them. You can just slide it in between their legs, make sure their buttocks is right here, and then slide it back out. The fracture pan, if they can't lift their hips far enough off the bed, you may have to have them roll on their side, put it onto their bottoms, the bottom is right here, and then lay them back flat on their bed so that they can urinate on it. We're going to talk about putting the person on the bedpan. They have to be in the supine position. So lay the head of their bed flat. Put the bedpan underneath them, and then raise their head up into semi-Fowlers. So they need to be sitting slightly, at least 35 to 40 degrees on that bedpan so that they can urinate into the bedpan. Now, women use bedpans to urinate and also to defecate. Men only use bedpans to defecate or to have a bowel movement. So a man is going to urinate in a urinal. It's not to say that men don't accidentally pee in the bedpan when they're sitting up trying to have a bowel movement. But you should offer the man the urinal first. He can pee in the urinal, and then he can sit up on a bedpan, and he can have a bowel movement in the bedpan. But a woman is going to urinate and defecate in a bedpan. You can dust the bedpan like we talked about in the skin chapter just to make sure that that person is not going to shear their skin when they come off that bedpan. So here it is, we're placing the bedpan underneath the person. Always have gloves on when you're touching your bedpan. And you can see that they are sitting with their bottom on this curved edge, and there's a little bit sticking up at the end so that it has room to go in. When you urinate, it doesn't just dribble straight down. It comes out and then down. Lower the head of the bed as far as possible, as far as comfortable for the person. Have them lift the buttocks off the bed and then slide it underneath it. Then you're going to raise your head back up 35 to 40 degrees so that they can urinate on the bedpan. Give them the call bell, provide them privacy, check on them every 5 minutes. Covering the bedpan when you leave the bedside for emptying just so that you don't spill it all over the place. And you're never placing it on a bedside table or any place that's going to have food or supplies. Your bedpans, never pouring the contents down the sink. You are going to dump your bedpan into the toilet. You're going to rinse your bedpan with some water from a special faucet or from a cup of water, and then you're going to dump it into the toilet. You're never putting any of this in, around, or near the sink. If you don't have this special faucet, you still are going to then just get a pitcher of water or a cup of water, fill it up, and then come over to your toilet, clean out your bedpan, and dump it all into your toilet. Never take your bedpan and rinse it underneath the residence sink. Okay. This is just going to be a video that talks about the different types of bedpans.
Since physical conditions of the residents you will be called upon to assist with a bedpan will vary, you should become familiar with the 2 common types of bedpans. The standard bedpan can be placed by asking the resident to lift his or her buttocks and then sliding the bedpan underneath. If the resident is unable to lift the hips, turn the resident on the side, position the bedpan, then assist the resident to return to the back while holding the bedpan in position. Elevate the head of the bed for comfort. The fracture pan is easier to place under a resident who has a hip or pelvic fracture or is unable to lift his or her buttocks. This bedpan may be more comfortable for residents who are small in stature. As with any procedure, start by performing beginning procedure actions. This will include gathering the following items: gloves, bedpan, bedpan cover, bed protector, toilet tissue, basin of water, soap, washcloth, towel, and laundry hamper or plastic bag.
Okay, so we're going to watch the video about me putting someone on the bedpan, and then we're going to practice in class also just putting each other on the bedpan. Okay. Important part of the bedpan, make sure that they are laying flat when you put them on the bedpan, and then you take off your gloves before you raise their head back up. And you always have a bed protector underneath the bedpan so that your bed isn't getting wet. If you do stick the bedpan underneath there and it drains or it dribbles or it leaks, then you need to change the whole bedding or the sheeting. So you're using your bed protector to protect your bed, but if you do accidentally spill some urine or stool, then you're going to need to change the sheets. Different types of other places, you could use a bedside commode instead of using a bedpan. So if your resident is allowed to get out of the bed, if they're not on complete bed rest or CBR, then they're allowed to get up, but they may not necessarily be able to get up and get all the way to the restroom in time. You can use a bedside commode if it's ordered. The bedside commode is like a portable toilet. They have to be able to transfer to use it. And you're going to put it on their strong side, and you're going to transfer their strong side first. Stand them up, pivot them to the toilet, bedside commode, just like we do putting them in a wheelchair. Help them pull down their pants, help them pull down their briefs, and then set them onto the bedside commode. The bucket that's in the bedside commode gets cleaned out after every use to help promote dignity and reduce smells. Make sure they have their shoes on before you get them out of bed, and make sure that you're cleaning it completely and immediately after use. Now, if the resident is not using a bedpan or a bedside commode or just walking to the regular toilet, they may have to have a brief on or an adult diaper. We don't call them diapers, we call them briefs or attends. They look like pull-ups sometimes, where they're all kind of nice and elasticy on the sides, and they just pull them up and down just like underwear. Sometimes they have the Velcro on them, just like baby diapers, but we don't call them diapers with the adults. Again, if someone has them on, you cannot tell them, just go in your diaper, you're covered. If they want to go to a commode, if they want to use a bedpan, you get them up to the commode or you get them a bedpan. But if they are incontinent, so they are unable to hold their urine, they are unable to hold their stool for whatever reason, then that incontinent person has on these briefs, and every 2 hours they need to be checked to see if they are wet or if they are soiled. And then we need to change them. When you're changing the briefs, the person is laying in the bed and you're rolling them from side to side and using wipes or toilet tissue to clean up their peri area. We're going to go over peri care and catheter care in this chapter, but you need to make sure that you're always wiping from front to back to prevent infections. You're also helping to promote their skin integrity. You're getting them clean, you're getting them dry with each diaper or with each brief change. You can't let them just soak in wet diapers for your whole shift and then change them one time. You also cannot double brief them. You just put one brief on at a time. Some people like at homes, or they come from a place where they put 2 briefs on top of each other. That just keeps in too much moisture. Okay, if the person is leaking outside of their brief more than every 2 hours, they need to be checked more than every 2 hours. Check them every hour then and see if the brief is wet. To put a brief on, you have to fold it in half first and then put it against the person's back. Roll them on their side, put it against their back as it's folded in half, and then roll them back flat on top of it, pull it in between their legs, and Velcro it around. We'll go over that and practice that in the clinical room. But make sure you know how to put the briefs on, take the briefs off, and then when you're getting the person up and down to the bedside commode, you're helping them get the briefs on and off and changing them with each change. If they're wet or soiled, they need to be changed. Okay. Other types of equipment when we're doing measuring urinary output. If it's strict eyes and O's, and we have to know how much urine is coming out, sometimes they may tell you to put a collection hat in the toilet. If they're going to the toilet and there's water already in the toilet, you need to measure how much urine is coming out each time. You're going to put this collection hat in the front part of their toilet, and then when they pee, it'll go into the collection hat. You're going to take the collection hat and pour it into a graduated cylinder to measure it. We're going to talk about measuring urinary output, and you always need to measure it in a graduated cylinder. The collection hat has little graduations on it that give you an estimate of how much is in there. So if you're not on strict eyes and O's, you can do an estimate. Sometimes people just want to know they feed about 300 this shift. If you don't have strict eyes and O's, you also could just put urinated times 1 or bowel movement times 1. You need to make sure you're documenting your output. Even if it's not strict eyes and O's, we still need to know how many times they urinated your shift and how many times they had a bowel movement that day. If they don't have a bowel movement in 3 days, we have to start giving them medications, enemas, suppositories, things that will make them stimulate to have a bowel movement. So it's important when they have a bowel movement that you are writing that down. Sometimes we need to do a stool collection. So if we're collecting the stool, you're going to put your collection hat towards the back of the toilet. And in the collection hat, it tells you this. It says front for urine, back for stool. Sometimes the toilets have 2 of them in there to catch the front and the back, whatever's coming out. You just need to plan ahead, use your equipment, and know what you need if you're doing I's and O's that are strict I's and O's. Or if you're collecting a stool sample. You don't want that stool to fall into the toilet water, or you don't want that stool to get contaminated with urine, so you separate it from the urine with a collection hat. Other types of urinals for men. Men use a urinal. Women are not supposed to use a urinal. This is not a medically approved device. I'll show it to you. It is something that somebody came up with for Amazon, but you are not really supposed to use these for women. Okay? A man has a urinal, and we'll see that, and it has a lid on it, and you need to close the lid as soon as it's used to keep the urine inside, just like you cover the bedpan when it's finished so that you don't spill it. We're also going to talk about the 24-hour urine collection. You have a big, huge, orange gallon-sized container that has a lid on it. For 24-hour urine, it's your responsibility. Every urine that they have for the day, either they're going to urinate in a urinal or they're going to pee in a collection hat, and you're going to pour it into this 24-hour collection, and it goes to the lab. If they forget to urinate into the collection hat, or if they wet their bed, or if they go in the toilet, you have to start over with this 24-hour collection. But it's your responsibility to keep this thing on ice. So you keep it in their room, in their bathroom, in a bucket full of ice, and the whole 24 hours it's on ice. So we'll show you that, and we have one in the clinical room for that we'll talk about. When the male residents, if they're using a urinal, they still need to have their head raised at least 35 to 40 degrees to be able to sit up and urinate in their urinal. Some men like to sit off the side of the bed and urinate. Some men like to stand up and urinate. But whatever their preference is, as long as it's okay with their care plan and they're allowed to get out of the bed, then they can stand up and urinate in their urinal. Give the resident the call bell, provide him privacy, every 5 minutes check on him, and make sure you're closing the lid before you leave the bedside with it. Again, don't put it anywhere on the bedside table, don't stick it to their handrails, don't leave it in the bed with them. It needs to go in the appropriate location. Put it in a trash bag, put it in the bottom drawer of their dresser, put it back in the bathroom, wherever they're going to store it, a holder on the side of the bed. But make sure that you are conscious that this urinal, you have to wear gloves whenever you're handling the urinal. Okay? This is just a video about using the urinal.
Before you begin this or any procedure, perform your beginning procedure actions. You will need to gather your equipment and supplies, including disposable gloves, bed protector, urinal with cover, a basin of water, soap, washcloth, towel, and laundry hamper or plastic bag. Put on disposable gloves. Hand the resident the urinal. If the resident is unable to take the urinal, lift the cover and place it between the resident's legs. Insert the penis into the opening. Remove your disposable gloves. Raise the side rail. Discard your gloves and wash your hands. Give the resident the call signal and leave the room. Return immediately when the resident signals that he is finished. If the resident does not call in 5 minutes, return to check on him. Continue to check on the resident's well-being every 5 minutes thereafter. Fill the wash basin with warm water. Place a disposable glove on the hand you will be using to carry the urinal. Ask the resident to hand you the urinal. If he is unable to, remove it using your gloved hand. Always close the urinal if the resident has not already done so when leaving the bedside for emptying. Take the urinal to the bathroom using the ungloved hand to open the door. Empty and disinfect the urinal according to facility policy. Store the urinal in its proper location. Remove and dispose of your glove following the facility's policy. As after any procedure, remember to wash your hands. Lower the side rail so you can provide the resident with assistance. Assist the resident to wash his hands. Raise the side rail of the resident's bed. Now perform your procedure completion actions. Report or record the resident's output. Be sure to note color, amount, and any abnormalities. Report abnormalities to the nurse.
Okay, so just make sure you know how to use your urinal appropriate for men or for males. And then, just like with the bedpan, they need to be in a Fowler's or semi-Fowler's position in order to use this urinal. It's very hard to pee laying flat or supine on your back. So some people have indwelling Foley catheters. If they are having bladder issues, then they have a catheter that's going through their urethra and it goes directly into their bladder. It's going to be collecting into a collection bag, and your role for these people, this is still their output. This is how they urinate. They're going to have urine coming through this tubing continuously. You need to make sure that it's not getting infected. So your role is to help prevent infection. We're going to learn how to clean the catheters. If you don't place the catheters in, but if you see a catheter that has been pulled out, you need to let the nurse know so that we can come and fix it. It's a sterile procedure to put the catheters in, but you need to help with cleaning the catheters. So the catheters need to be cleaned every shift to help prevent infection. The bags are only changed like once a month, so we need to make sure we're keeping the tubing cleaned that goes into their body. Always wear gloves when you're handling or emptying this bag. You're going to empty it into a graduated cylinder, and we're going to practice with that in the clinical room. Make sure you're providing daily care for this. You're cleaning at least 4 inches from the meatus with a washcloth, pulling in strokes away from the body, but not stretching the catheter as you're cleaning it. Okay? While you're holding the tubing at the meatus, you're not pulling it out from their body. And making sure that this catheter is kept as clean as possible. You also need to make sure that it's draining properly, that the tubing isn't kinked, that they're not laying on the bag, that they're not pulling it out when you're turning them from side to side. You're always going to move your bag first and then move your person, but you need to make sure that that bag stays below the level of their bladder at all times. If you raise it up above the level of their bladder, it's going to backflow into their bladder, or the tubing, the urine will go back from the tubing back up into their body, and that could cause infection. So you need to prevent it from pulling out. When you're ambulating, it's taped to the inner thigh of the person. When we'll show you on Susie with her little thigh clip where it's taped at with that little Y. So your intention is so it's taped to their thigh, or for men on their abdomen, but taped there so that it's not pulling out of their body when you get them up and move them around, or even when you roll them from side to side. Just be cautious of this tubing and know that this thing is going up into their bladder. At the top of the catheter, this is the Y portion that you're going to have taped to their thigh. But at the top of the catheter, the one that's inside their bladder, there is a plastic balloon. It's about the size of a $50 or a quarter. And it would be painful if it pulled out through their urethra to come out. So we'll play with those a little bit in the clinical room. But if the tubing comes disconnected from the bag and the catheter, so the catheter is this rubber portion right here. If the tubing comes disconnected right here, it's good because it didn't pull out of their body. Okay, you've taped this Y area to their thigh, and then it would come apart right here. If it does, then you're going to just clean both sides with alcohol and stick it back together, and then let the nurse know. Okay, we're going to play with a few of them with emptying the Foley bag. They all have different valves at the bottom of them of how you empty them, clips to keep them closed. But you unclip it and then you stick it up into its pouch so that this clip isn't dragging on the floor either. There are also a lot of different policies about covering the bag. There's some privacy bags that you put on top of these bags. Some of them have pre-built-in flaps that flap over it so that you can't see that this bag is filling up with urine when the resident's walking around the hallway or getting out in public. You're always going to make sure the bag stays lower than the bladder, so you're going to hook the bag to the bed frame, or you're going to hook the bag to the frame of their wheelchair. Don't hook the bag to the wheels of their wheelchair where they're going to roll over it. Don't make sure the tubing isn't dragging on the ground as you're wheeling them around. Okay, there's a clip on the tubing too that you can keep it up and off the ground. And the bag should never be dragging on the ground either. Okay? If it comes out of the body completely, or if you see it's pulled out a long ways more than it normally looks like, let the nurse know. You have to empty this bag every shift, at least every shift. Now the bags hold 2 liters, so the bag should not fill up to the brim in your shift. If you notice that this bag is filled with water, it just looks like clear liquid and there's a ton of it and it's bulging out, you need to let the nurse know immediately, because that means there's something wrong with the person. If during your 8-hour shift you only have a little bit of urine in the bottom, like 25 cc's of urine, you need to let the nurse know. People make about an ounce of urine an hour, so you should have about 30 cc's of urine every hour. So even if they weren't drinking or they weren't having a lot of fluid in, within your 8-hour shift, you should be emptying between 250, 300 cc's of urine every 8 hours. So empty it every shift. Make sure you clamp it tightly back up and then put it back up into the holder so it doesn't drag and get contaminated. This is what it looks like inside of your bladder. So your bladder is like a big pouch and it's constantly holding urine. We're going to put the indwelling Foley catheter up, blow up the balloon, and these little fenestrated areas at the tip of the catheter, which we'll look at, that's where the urine is going to go in and then come out into your Foley bag. So this is a video about your indwelling Foley catheter, which basically it's just telling you that catheter care is important.
Indwelling catheter care can be performed during routine morning care, as part of perineal care, or as a separate procedure. As with any procedure, start by performing your beginning procedure actions. Cover overbed table with a barrier following your facility's policy. Place your equipment upon it within easy reach. These items will include the following: gloves, catheter care kit or basin, soap, 2 washcloths, towels, clean gown or clothing, bath blanket, and linen hamper. Perform male or female perineal care following the procedures outlined earlier. Hold the catheter to one side and support it well to prevent irritation and pulling. Using a clean washcloth, wash the catheter beginning 3 inches from the point of insertion into the body. Begin at the urinary meatus and wash downward. Avoid a back and forth motion. Thoroughly rinse and dry the tubing. Secure the tubing to the leg to prevent irritation and pulling. Make the resident comfortable and raise side rails. Remove gloves and wash hands. Perform your procedure completion actions. The following are some general guidelines to follow concerning a closed urinary drainage system. Always wash your hands and apply gloves before handling. Never disconnect the catheter, bag, or tubing. Never allow the bag to touch the floor. Make sure the urine is flowing freely. Keep the catheter secured to the resident's leg to prevent pulling. Fasten the bag to the bed frame. Never hang it on the side rail. Always keep the bag below the level of the bladder. Notify the nurse if the resident experiences any type of discomfort or if you find any abnormalities that are caused by the catheter.
Okay, so we're going to watch the video of me doing catheter care on Susie, and you're going to have to do catheter care on females and males. But the catheter care is just cleaning the tubing of the catheter. Make sure you're holding on to it at all times. In that video, she put an excessive amount of tape on this person's leg. You don't need that much tape, but she taped it onto her inner thigh, and now they have like stay locks. So Susie has a stay lock on her where it's just a little a little patch, and then there's a clip on it that holds the Y part of the tubing so that it won't pull out of her body. That's catheter care, and then we're going to practice doing that. And for the men, same thing. You're going to lift their penis and hold on to the end of the catheter and then clean it at least 4 inches from the insertion site of the body. Other types of drainage equipment, sometimes patients are going to have wounds and they're going to have a bulb or some kind of drainage system that you may need to help measure with. We also measure emesis or vomit. So if we are having someone who's vomiting, we're going to give them a kidney basin to vomit into and then pour that and measure how much emesis is coming out. So know that the word emesis means vomiting. Okay? A Jackson Pratt bulb is this bulb right here that comes from people who have surgeries. Sometimes they're attached to them. They're just stitched at the skin, and then they have a safety clip that's clipped onto their clothing. So make sure that they're not getting pulled out. But the bulb has to be charged in order for it to be sucking the drainage out of their body. This bulb on the bottom is not charged. That means it is just open. It looks like a bulb. It's not going to be sucking out any drainage anymore. The bulb at the top is flattened or squished down in the middle. That means it's charged. That means that there's some suction inside of that bulb that's going to be pulling the drainage into it. So the drainage comes in through a tube, and this little valve at the top is what you're going to open and close to open it and then squeeze the bulb down and then put the top back in it, and the bulb will stay charged. Okay? You have to get trained on this. The first time you see it, the nurse will help you with it. Just ask if you need help. And make sure you're always wearing gloves. Even if they're having emesis, you're wearing gloves when you take that kidney basin from them. Okay? But charged on these bulbs means that they're squished down. You also want to make sure the tubing on these bulbs aren't kinked. And again, that they come with the person when you're moving them, just like the Foley catheter tubing. You're not pulling them out as you're moving the person around. Your graduated cylinder is what you have on your buckets that you took home. It's this triangular container that has increments of measurement on it. One side has milliliters or cc's. 1 milliliter is equal to 1 cc. It'll say milliliters or cc. It's the same thing. The other side has ounces on it. I don't know why, because we don't measure in ounces, but you are always going to measure on the cc side. But you know that 1 ounce is equal to 30 milliliters. So if you do measure on the ounce side and you get 6 ounces, you're going to multiply your 6 ounces by 30 and get 180 milliliters or 180 cc's and write that on your chart. Okay? So graduated cylinders are the most accurate way to measure. You're going to pour the urine from any other collection container into the graduated cylinder to measure it if you are on strict I's and O's. We're going to learn how to do this. We're going to do measuring urinary output in the clinical room, but make sure you're putting it on a level surface and a covered surface, and then bending down and looking at it at eye level to measure it accurately. You're not measuring the bubbles or the foams on the top. You're just measuring where the urine is. And then you're measuring in increments of 25. So there's quarter systems on this that we'll go over. Always read it at eye level, always read it in the ounces side, and then rinse it out and dispose of it all into the toilet. So you still need to rinse your graduated cylinder and pour the rinse water into the toilet as well. Okay. So we'll go over that in the classroom as far as doing the urinary output or in the clinical room. But sometimes you're going to be asked to get a sample of urine. So if you're asked to get a sample of urine, we'll go over that a little bit later. But for the Foley catheter, I'll show you, you never get the sample from the Foley bag. You need to crimp off the tubing. This is the only time we're allowed to crimp the tubing. So crimp the tubing with a rubber band or tie off the tubing close to the specimen port, close to where it goes into the Y of the actual indwelling catheter part. Crimp it off, and leave it crimped for about 20 or 30 minutes, and then some urine should back up into that catheter tubing. With the urine in that tubing, you're going to then screw into that collection port a syringe and then pull out about 10 cc's of urine from that collection port. But if you are asked to get a collection from a Foley catheter and you don't know how, just ask for help first, but never get it from the bag, because the bag has been hanging there for 20, 30 days. It probably has bacteria in it. We're trying to get a fresh sample directly from the body, and you're going to get it out of that little specimen port. Catheter care is independent of perineal care. Every time you clean, you're going to clean the catheter at least once a shift, but then you may be doing perineal care as well. So, or you're going to do perineal care and maybe not necessarily do catheter care. When we are cleaning on Susie, her catheter is going to be in. Whether you get this bill for catheter care or peri care, her catheter is there. You still need to do peri care with people who have catheters. You just need to work around the catheter and make sure you're not pulling it out. But perineal care is how we clean your private areas. Okay? You're placing an incontinence pad or a bed protector underneath their bottom before you start your perineal care so that you're not getting their beds wet. Make sure you have on your gloves before you place anything underneath their bottom, because they may already be wet under there. But you need to put on gloves before you put your bed protector under. Drape your resident to prevent overexposure. You're using your bath blanket, and you're only exposing the perineal area. Okay? Put on your gloves. Wash the pubic area first. The pubic area is the front. So we're always going from front to back. So pubic area to anal area or rectal area. Anal, rectal is the back. So front to back, and it's called peri-care or perineal care. You're using different parts of the washcloth for each wipe, so you're not contaminating things, and you're definitely not going from the back to the front, because you could put stool into their urine or their urethra, and then it could cause them to have a urinary tract infection. With the man, you're going to hold their penis up at a 90-degree angle. You're going to use circular strokes around the top of the penis, retract the foreskin and clean under the foreskin if they're not circumcised, and then use long strokes from the top to the scrotum. So same thing, from top to bottom, so front to back. With your perineal care for anyone, always make sure you're cleaning it, you're rinsing it, and you're drying it thoroughly. So you put a little bit of soap on there. You need to get off all the soap that you put on, or it's going to cause infection. You're going to turn the resident on their side. You're going to wash their anal area or the rectal area from front to back as well. So the front is called the perineum, and the back is called the coccyx. So, or the front part of the body is the perineum. The back side of you is your coccyx side, front to back. Okay. You're rinsing and drying everything thoroughly, using a clean washcloth for each step. Wash, rinse, and dry. And we're going to practice on Susie, and this is Susie's area here. We're going to go from the top of the fuzzy up here, and we're going to go straight down to her anal area with one wipe. Then we're going to change our washcloth around, and we're going to start over here on the top of the fuzzy of her meatus and come down the side of her labia to this fuzzy part here. We're going to get a new washcloth, change the washcloth around, and then come from this side on the other side of the labia and come down to the anus. Okay. Then when we flip Susie over, we're going to start where we left off, right here at the anus, and go upwards. But we're still going from perineum to coccyx. So perineum's down here, coccyx is going upwards. This is your coccyx up here. Okay. Then we're going to take it here and go up, and here and go up with different areas of the washcloth each time. So down on the front 3 times, up on the back 3 times, but it's still going from perineum to coccyx. Okay. The video is going to show you how to clean a male And then we're actually going to physically do Susie, and we also have the adaptation for Susie. That's what these little fuzzy things are, is where we're going to stick her penis on. And then we'll practice with doing the male also with the mannequins.
As with female perineal care, male perineal care may be performed as part of general bathing or as a separate procedure as needed. Since you will be washing the area including the genitals and anus, always wear gloves when performing perineal care. Perform your beginning procedure actions. As part of this procedure, gather the supplies you will need, including basin, soap, 2 washcloths, towels, clean gown or clothing, disposable gloves, bed protector, disposable underpad, plastic bag, and laundry hamper. Follow your facility policy for covering the overbed table with a barrier. After cover is in place, arrange your supplies upon the table for easy accessibility. Offer the resident the bedpan or urinal. If you will be assisting the resident, apply the principles of standard precautions. Fan fold the bedspread and blanket to the foot of the bed, or remove and place them on a chair. Place the bath blanket over the top sheet and ask the resident to hold it in place. Remove the sheet by pulling it down from underneath the blanket to avoid exposing the resident. Place the soiled sheet in a hamper or plastic bag, or dispose of it according to facility policy. Remove the resident's gown if wet or soiled, and dispose of it according to facility policy. If the gown is clean, you may omit this step. Remember to keep soiled linen away from your uniform. The resident should be on a clean, dry surface. If the linen is soiled, dispose of it according to facility policy. Assist the resident to raise his hips and place a bed protector under the buttocks. Disposable gloves should be worn if a wet or soiled bed protector is to be removed. Raise the resident's side rail. Fill a water basin with warm water. Check the water temperature to ensure it's comfortable to your touch. Return to the resident's bedside and lower the side rail. Position the bath blanket so the area between the legs is exposed. Keep the resident covered as much as possible for modesty and dignity. Assist the resident to separate and bend his knees, placing the feet flat on the bed if able. Put on disposable gloves. Make a mitten by folding a washcloth over your hand. Apply soap to the washcloth. Avoid using too much soap as it can be irritating to the skin. Grasp the penis gently and begin washing at the urinary meatus. Work outward in a circular motion. Continue to wash down the penis using downward strokes. If the resident is not circumcised, gently pull back the foreskin and wash this area. Rinse, gently dry, and replace the retracted foreskin. Wash the scrotum. Then gently lift the scrotum and wash the perineum. Rinse the washcloth. Use the washcloth to make a mitten. Rinse the entire area, beginning with the penis. Rinse well, working in the same direction until entire area is soap free. Use a towel to gently dry the area. Assist the resident to turn on his side away from you. Flex the upper leg forward if resident is able. Make a mitten with a wet washcloth and apply soap. Expose the anal area. Wash from the perineum to the coccyx. After rinsing the washcloth, rinse the anal area well. Gently pat dry with a towel. At this time, assist the resident to return to his back. Cover the resident and adjust the bath blanket for modesty. Remove and dispose of the bed protector according to facility policy. Place soiled linen in a hamper or plastic bag according to facility policy. Remove one glove and raise the side rail with your bare hand. Practice your facility's policy for disposing of your gloves. As with this and any procedure, remember the most effective tool for infection control is hand washing. After washing your hands, return to the resident's bedside and lower the side rail. Replace the top covers and remove the back blanket. Fold the back blanket and store. If unable to reuse, place in hamper according to facility policy. Help the resident into a clean gown or clothing of his choice. Once the resident is comfortable, perform your procedure completion actions.
Okay, so per facility policy, sometimes they're going to reuse the back blanket as long as it's not dirty. But for testing purposes and here in class, we're going to put that back blanket in the hamper every time and put it in soiled utility. The biggest thing with the infection control is they don't want you to touch a lot of things with your gloves that you've just handled a bedpan or urinal with. So just be cautious about, you have gloves on, that you've just touched something dirty. You don't want to be handling all of their sheets and handling all of their blankets and pulling on their side rails with these contaminated gloves on. Okay. So make sure that you are following your facility's policy. You'll get that in orientation, what they expect with covering your overbed table, with using either wipes or using washcloths, whatever your facility uses. But when you're cleaning anyone, if it's male or female, if they have soiled their clothing, you need to rinse that clothing out. So take it to the soiled utility room and rinse it out into the hopper that's in soiled utility. You don't want to rinse it out into their sink. But take it into soiled utility in a trash bag or a linen bag and rinse out any excess urine or stool before you put that in the laundry. Don't just wrap up stool in someone's clothes and send it to laundry in a hamper. And definitely don't leave it in their room if their family does their laundry. So we talked about in another chapter, sometimes family members come and get the patient's laundry, but they don't want to pick up laundry that has stool and urine inside of the bag with everything else, because then they're going to have to throw all the clothes away. But just be cautious about rinsing it out in the hopper that's in the soiled utility room that's specifically made for that. It's like a little urinal with a spigot on it that you can rinse out the stool and urine and clean off the clothes a little bit before you put them to laundry. Okay, the video of me is doing female peri-care, and we're going to work on that with Susie, and you'll have an opportunity to do both male and female with Susie. We'll also do putting them on the bedpan, putting on the briefs, measuring the urinary output. All of those things we're going to work on later on in the clinical room. Your urination concerns. Report any of the following to the charge nurse. If somebody is having a problem with urinating, you need to let your charge nurse know. Okay, if they complain they're having a burning sensation when they urinate, that's called dysuria. It's painful urination. If a little old lady tells you, oh, I don't want to pee because it hurts to pee, let us know, because she's probably having a urinary tract infection. If they have foul-smelling urine, if you see blood in their urine, if the urine is a different color than what normal urine looks like, let us know. That includes urine being really, really clear that just looks like water in large amounts. That means there's something wrong with them. They can get dehydrated very easily. If they're making frequent trips to the restroom, if they keep putting on their call light every 15 minutes and say they have to go to the bathroom and only pee in a little tinkle each time, let us know. If they have small amounts of urine where they're going a long time and nothing is coming out. If you have a Foley catheter and you've noticed it's been 2 or 3 hours and there's no urine in the bag, you need to let us know immediately. Okay? Urinary tract infections start with everyone down here at your urethra. Females have a little bit shorter urethra than men do, but everybody gets urinary tract infections. Your urethra leads up to the bladder. The bladder goes up your ureters up to your kidneys. This bacteria can travel from your urethra to your bladder, up your ureters, into your kidneys. When it gets to your kidneys, it gets into your blood supply and then contaminates your entire body. So we need to try to catch it early when it's just down here at the urethra and it's causing a little bit of concern. they're having a little bit of burning when they pee, or they're having to go a little bit more frequently. By the time it's gotten all the way up to their bladder and their ureters and into their kidneys, they're going to start complaining of side pain and flank pain and back pain because they have a kidney infection. But let us know if they're complaining about any kind of abnormal back pain or abdominal pain or distension. Sometimes if the bladder is blocked up and they haven't urinated in hours and hours and hours, they start getting distension in their abdomen. More frequent trips to the restroom as a normal part of aging, the bladder does hold a little bit less, but they should be able to go at least 2 to 3 to 4 hours without having to go to the bathroom. The small amounts of urine, normal urine is 1 to 1.5 liters per day. If you have any cloudy urine or lower abdominal distension or discomfort. Okay. If they haven't urinated during your shift, we definitely need to know. If it's been 4 to 6 hours and you notice they haven't urinated, go on ahead and let your nurse know. If they've never been incontinent, but now they are incontinent, or if they've had an accident, they usually are able to get up and go to the bathroom, but now you notice they're incontinent, unable to hold their urine, and urinating in the bed or urinating on themselves, let us know. Stress incontinence is when you sneeze or cough. It's sometimes normal, but it could also indicate a problem. Usually women, after they've had a baby, it's kind of loose with their muscles down there, and they sneeze and a little bit of urine dribbles out. That's normal. But if it's never happened before, and now it happens all the time, then we need to know. Some women get urinary prolapse or bladder prolapse, where the bladder just drops and falls, and then just let us know these things are going on. Of course, your dark urine, your concentrated urine, a UTI with the lower back flank pain, and then also neurological changes. As people age, for some reason, some of them, when they have urinary tract infections, start having a little neurological or cognitive deficits. Maybe they're more confused than normal. Maybe they're more aggressive than normal. But that kind of mental status change can sometimes indicate that they're having a neurological change that's related to a urinary tract infection. Sometimes they get paranoid and start telling you things like people are crawling, or people are watching them, or people are poisoning their food. Let us know those kind of ideations that they have. Bladder retraining. A bladder retraining program is a scheduled toileting program. This is for people who have had some kind of incontinence, whether it be because of surgery or because of infection, or for some reason they had some bladder issues. And now we are trying to retrain their bladder to help prevent incontinence. We're helping them treat their incontinence, and we're trying to encourage them to be able to have the sensation of letting their bladder fill up like it normally should before they have to empty it continuously every 15 or 20 minutes. This is the only time you're allowed to let the residents hold it. Like normally when a resident says they have to go to the restroom, as soon as they press the call bell, you need to get to them immediately. Help them to the restroom. They should be urinating every 2 to 4 hours, and that's normal. But if they're on a bladder retraining program and they're pressing the button every 15 minutes and wanting to go to the bathroom, you need to let the nurse know, because we're trying to encourage them to try to hold it a little bit longer to retrain their bladder to hold enough urine, hold about 100 to 200 cc's of urine, not just get 30 cc's of urine and then have the urge to feel to go to the bathroom. So a bladder retraining program helps to prevent incontinence. It's trying to help with their dignity, to make them to where they can get back to going to the restroom like normal instead of being incontinent and having to wear incontinent briefs all the time. Okay. The resident has a Foley catheter in. We clamp the Foley catheter to let their bladder feel like it's filling up. If they have that indwelling Foley catheter, the bladder is constantly draining, so there's no feeling of sensation of fullness of their bladder. But then when we pull it out, then they're constantly having to pee. But sometimes you may have their Foley clamped for a certain amount of hours so that it builds up into their bladder, and then we unclamp it and then it'll come out. Just to promote bladder filling and retention to help with that incontinence before we pull that Foley out. Always make sure you're offering your fluids frequently. Never withhold fluids from the resident. Encourage movement and activity, and never restrict the residents from movement. Even if they have a Foley catheter in, they can still get up. They still need to get up, walk around, attach the Foley catheter to the bottom of their wheelchair, to the walker, move the bag, keep it lower than the bladder at all times, and take the bag with you and walk down the hallway. Okay. Some people have a Foley bag that's like a leg bag that straps onto their leg. I'll show you an example of that in the clinical room. Those people strap it onto their leg and walk around. So never restrict the resident's movement. This is just an example of the different types of incontinence. You don't really need to know what kind of incontinence the person has, but there are different reasons why people have incontinence. Your normal bladder, you have these muscles that help contract when your bladder is full, and that tells you you need to urinate and empty your bladder. Some people with an overactive bladder, the urine just fills up a little bit, and then they have this urge to go. With men, sometimes they have a blockage right here from their prostate. The prostate is blocking their urethra, so the urine can't flow out of them as easily. Then it backs up into their bladder and it isn't able to empty, but a little bit, the more pressure that's up here in the bladder, the more it squeezes little drops of urine and it just dribbles out of them. That's your overflow incontinence. Your stress incontinence is when these muscles are kind of overactive here, again in your pelvis, when you sneeze or cough and it pushes down on your bladder and it squeezes some of the little drip that drops out. Your urge incontinence is just an oversensitivity from neurological disorders. People can take some medicine for it. Sometimes it helps, sometimes it doesn't, but it's just these neurological signals that are just constantly firing, telling people that they have to pee, they have to pee. Same thing with defecating or having a bowel movement. Sometimes people have difficulty with having bowel movements. There is a chart that tells you all the different kinds of bowel movements. You don't need to know this. You just need to know that watery, liquidy bowel, entirely liquid, is diarrhea. But they have to have technically 3 runny, loose diarrheas for it to be called diarrhea. If you are having diarrhea, you really want to go on ahead and get it out. Don't take anything to stop yourself up, because the reason you're having diarrhea is there's some kind of bacteria or virus or something in there that needs to come out. As long as you're not getting dehydrated, have the diarrhea and get it out of your system. If you become dehydrated, you need to let the nurse know. But if your person has had diarrhea, you need to let the nurse know. But there are different stages of stool. If your stool is really hard and lumps and looks like little nuts when they pass it, that person is dehydrated. They need to be drinking more fluid. And if they're having difficulty moving their bowels, straining more with bowel movements, if you see a bowel movement that comes out that's watery or smells really foul, or it's not the normal soft brown. Now sometimes it can be greenish because of food dye. Blue food dye makes your poop look green, your stool look green, okay? But normal stool is going to look like a sausage, smooth and soft. If it comes out black or hard or watery, you're going to let us know. Okay. If your abdomen is bloated, if you have swelling tissue around the rectum where the stool is coming out, that's their hemorrhoids. Some people have internal hemorrhoids. Some people have external hemorrhoids where you can actually see them hanging off the end around the rectum. Just be careful when you're wiping them because they are very tender and very sensitive. And there may be some blood that comes off of them. If the resident has more difficulty getting to the bathroom, or if they have fecal incontinence, the fecal incontinence, just like urinary incontinence, is the inability to control the passage of feces or gas through their anus. So gas is called flatulence, but sometimes people have feces that just come out and they don't even know it happened. Okay, so that is something you need to report to the nurse. If you go in to help change them and you ask them if they have gone and they say no, and then you notice there's a whole bowel movement in the brief and they don't even know that it was there, then you'll need to let the nurse know. If the resident has not had a bowel movement in several days, they could start having nausea because they're going to be backed up. It's all connected from your esophagus through your stomach and down your small intestines and through your large intestines like we watched in the anatomy chapter. So if all of their large intestine is backed up and their small intestine is getting backed up and there's no place for anything to come out, it's going to come back up into their stomach and they're going to get nauseated. A decreased peristalsis as we age, decreased movement of these intestines is what causes constipation. Also, using pain relievers. Pain medicine causes constipation because it slows down the peristaltic waves, it slows down the movement in the body. So this is what we always need to make sure people are moving around.
Some of the signs and symptoms of gastrointestinal system problems include sores or ulcers inside the mouth, difficulty in swallowing or chewing food, or choking, frequent belching, changes in appetite, indigestion or excessive gas, nausea or vomiting, or coffee ground appearance of emesis or stool, dark or bright red blood in emesis or stool, and abdominal pain or distension. In a resident with distension, the abdomen will enlarge and appear bloated. This is an important observation to report to the nurse. Abdominal distension is commonly caused by excess gas, constipation, or urinary retention, although it may also indicate a more serious condition. Other signs and symptoms may indicate difficulty in elimination. These include unusual or abnormal appearance of bowel movement, blood, mucus, or other unusual substances in stool, unusual color of bowel movement, hard stool or difficulty in passing stool, complaints of pain, constipation, diarrhea, or bleeding. Diarrhea is the passage of 3 or more loose, watery, liquid stools in a day.
So again, with your bowel training aids, sometimes people are going to need help with elimination, but we are supposed to be observing the client's normal elimination patterns and letting them go to the restroom and reach their bathroom needs according to their own patterns. Everybody has their own way of doing things, and it's been their whole life like that. Some people get up in the morning, first thing they do, go to the bathroom, read the newspaper, have a bowel movement. So that's their normal elimination pattern. We need to make sure that we help them with that. Help people eliminate after meals. Help people eliminate every 2 to 3 hours. Help people eliminate before they go to bed. Sometimes you're going to have to use the incontinence products. So the incontinence product is your brief or your Attends, but you never call it a diaper. But this incontinent product is going to keep our garments clean. It is for people who maybe can't hold the stool or the urine till they get to the commode. But you need to make sure that you're checking it frequently, cleaning it often, changing it appropriately. With people who have incontinence products, you have to make sure that you know what size they wear, what kind they wear. They come in different sizes. They come in ones that look like diapers. They come in ones that look like pull-ups. So know what they wear, what product to use, and what size to use. Also, some people use barrier creams. These barrier creams like zinc oxide or baby butt paste, as long as they don't have medication in them, sometimes you can put a barrier cream on their skin. You'll be able to put that on yourself with each diaper change or with each brief change. Or the nurse has to put on the ones that have actual medications in them. But sometimes you can have these barrier creams that you can use with each diaper change, and it'll be part of their care plan. So know what kind of incontinence product they're using, know what size they need to use, and then know what abnormalities you need to know to report to your nurse. You're always following your resident care plan. You're on that care plan. It's going to tell you everything you need for these elimination needs. With your bowel training aids, sometimes we're going to have to help with the suppository. A suppository is something that the CNAs can help with. If you work in home health, you may have to give a suppository yourself. A suppository is going up the rectum, so it's not a pill by mouth. You are not allowed to give stool softeners because stool softeners are pills that go in the mouth. And sometimes you may have to help with an enema also. But a suppository and enema are going in the rectum. You'll have to be trained on how to do it, checked off by a nurse, and you can help with this. This is when you're going to put your patient in the Sims position, so semi-prone, laying on their left side with their legs bent, one slightly bent in front of the other one, the hand behind them like a running man, the butt's up in the air, and you're going to put your glove on and put your suppository just barely into their rectum, like right here. It's just to that first bend of your finger, and then it goes into the rectum, into their colon here. So a suppository has to be ordered by the physician, and it's going to help them with a bowel movement. The cone, it's like a cone-shaped piece of glycerin. I'll show you one in the clinical room, and it just dissolves with your body temperature. So it goes in the rectum, it dissolves to help lubricate the area, and then helps the bowel movement pass through. Okay. An enema is fluid that we're going to put into the rectum that fills up the lower part of the colon. It also has to be ordered by the physician. It's going to help remove feces, relieve constipation, get rid of a fecal impaction, helps with flatulence sometimes as well, but also putting this person in the Sims position. We have the bag in there. I'll show you. We're going to fill it with water, but you don't put the whole liter of water in them at one time. We just put about 100 or 200 cc's in and then clamp it off. And then roll the person back onto their bedpan and let it come out. And we'll do that however many times the doctor orders for it. It can be a soap sud enema, or it can just be a warm water enema. It can have saline in it. We can have oil in it. So everything is all ordered by the physician. Always report to the resident or to the nurse if the resident complains of cramping or severe abdominal pain. You're sticking something up their rectum. That tissue along the colon is very thin. You don't want to perforate it or cause a problem. So definitely don't put more than about 100, 150 cc's at a time into their rectum. The Fleets enema already comes pre-prepared. This is the one you usually see in home health. It comes in a bottle. It has about 120 milliliters in it. You take off the top. It's already pre-lubricated. You stick it in just the length of this cap and squeeze the bottle into the rectum. They're either going to then sit up on the toilet and come out into the toilet, or roll over onto a bedside commode or into a bedpan, and then the stool will come out. So make sure that you get checked off on that before you help a nurse with doing that. Your other bowel training aids, sometimes people with hemorrhoids have the little tissue hanging out near their rectum. A sitz bath is something to help relieve the pain. We talked about this in the pain chapter. It's warm water that's going to run over that tissue to help with the swelling and the pain. It cleans the affected area and increases blood flow to the area. It can be hot or warm or cold water, but it's normally warm water that we're going to use. And you're going to monitor your resident for fainting. They're going to be sitting up on a toilet. And I'll show you this. We have it in there as well. This goes on the toilet seat, and then the water can drain into the toilet through these vents in the back. We fill up this bag full of warm or tepid water, hang it from the pole, and then just let it drain, and then it just soothes the person's bottom area for 10 to 15 minutes. But when they're sitting up on the toilet with this running, sometimes it can cause them to get faint or dizzy. So you don't want to leave them in the bathroom by themselves on a sit bath. They may pass out and hit the floor. Sometimes if you have a quadriplegic or a paraplegic, someone with a spinal cord injury, these are the people that we're also going to be log rolling if they're in traction or spinal cord injuries. But sometimes they need help with bowel irrigation. They don't have the urge, or they don't have a signal that tells them to defecate. So a quadriplegic the person has no movement of all four extremities. A paraplegic, they have no movement of their lower extremities. And a hemiplegia is like a stroke patient that just has one-sided paralysis. But some of these people cannot feel the sphincter down there at their rectum to know that they need to have a bowel movement. For them, you're going to have to help them with what they call digital disimpaction. You are going to take your digit or your gloved finger, put a little bit of lubricant KY jelly on it, go around their anus slowly in a clockwise motion to stimulate a bowel movement. And that's called digital disimpaction. Sometimes people will have such hard balls of stool stuck in their rectum, the nurse would have to go in there and kind of dig it out of their rectum the same way, but you really shouldn't be doing that as a CNA. You really need to let the nurse digitally disimpact people that way. What you can do is just help the spinal cord injured people with a little bit of digital stimulation. And then just stimulate it slightly and slowly so you're not tearing any of this sensitive tissue in their rectum or anything. Some people do not have a rectum or aren't using their rectum. They're having a bowel movement through an ostomy. An ostomy is a surgically created incision on the side of their abdomen where their waste is going to come out. Sometimes part of their intestine is removed surgically because of a car accident or cancer or an injury, bowel disease, trauma, stabbing, gunshots. Ostomies can be a uterostomy for urine, where we're pulling their ureters to the surface of their skin. This is your kidney. Your ureter is coming down and normally takes your urine to your bladder, and then your bladder takes it out your urethra. But for some reason, if somebody has bladder cancer or they just aren't able to use their bladder, they put the uterostomy in. It's just a little flap of skin where it's surgically sewn to the surface of their body, and you're going to use a small in and out catheter to drain it every 3 to 4 hours. They stick the catheter in, they hold the graduated cylinder lower, it drains out your urine. So this uterostomy is a ureters to the stoma, or the opening for the urine. But more often you're going to see a colostomy, which is the colon. So a colostomy is, your colon is your large intestine, but your large bowel, and it depends on where they place it to what is going to be coming out of it. When it's more to the far right-hand side of the bowel, it's more liquidy. As it travels up and over the bowel, it becomes more solid. So if you have an ostomy on the right-hand side, it may have a pouch that's just draining brownish, greenish liquid out. As it comes up and gets more solid, maybe at the top of their abdomen on the left-hand side, and then going down the descending colon, sigmoid, down the left-hand side, it's going to look more like stool. And it's going to come out into a pouch that we're going to have to empty. So with your ostomies, they're going to have, this is a redness around the skin that we're going to try to prevent. The bag is only changed every 3 to 7 days because we can't keep pulling it on and off their skin every day or it's going to cause irritation like this. Okay, so when you have your stoma, it's sticking out. This is actually a part of their intestine. It should be pink. It should look like it has good blood flow. And you're not going to smush on it or press on it too hard because you can kill it or make it start dying off. But you're going to place the bag on top of the stoma and the stool is going to come directly out into your ostomy bag. We're going to work on emptying the ostomy bags, emptying the colostomy pouches, but make sure that that skin around the pouch is clean and dry. If it's leaking around there, then let the nurse know. So we have some creams and powders we can put there to try to help it re-adhere or stick better, but we really only change that bag every 3 to 7 days. This is what your colostomy pouch looks like. Again, it's coming off of his intestine. And we are going to make sure that we're emptying the pouch when it's 1/3 full. You don't let it get so full of stool and heavy that it's weighing heavily down and then going to come off the skin. If it's 1/3 full, you're going to empty it. So sometimes you may have to empty it 2 or 3 times during your shift. But make sure you're wearing gloves when you empty it. It has this adhesive backing that's on the back of it. Some of them have little belts. I have some I'm going to show you for examples. It has a drain on the bottom with a clip. Okay, when we're cleaning it, you have to fold the end up inside out, squish the stool out of it, or empty the stool into a graduated cylinder, and then clean off the end with a towel, toilet tissue, or wet wipe, and then pull it back down from being inside out and roll it back up and put the clip on it. So we'll work on that. Sometimes they're ballooned out because they have gas in them. If you go in and it looks like a blown up balloon but there's no stool in there, it still could pop off of the skin because of the pressure from the gas. So you have to unclip the clip, let out the gas, and then put the clip back on. So it's your responsibility to help these residents with their ostomy bags. They know how to do them. They have been trained. They have their little quirks. They can tell you how to do them. But however, they need to do them as long as it's safe. Keep it wiped. Keep toilet tissue close by. Make sure it's clamped good. Make sure it's not leaking. And again, we don't change the bag every time there's stool in there. The bags stay on for 3 to 7 days, or when it's leaked or falling off when we can't get it to stick back on. They're very expensive. It's like $300 or $400 for a box of 10 of them. So changing it too frequently is going to cause skin breakdown as well as a lot of excess cost for the person. But they are made to stay on for a week at a time, as long as you empty it every time it's 1/3 full and you're keeping it clean and dry. Okay, we'll work with those ostomy bags and go over some examples of those, and keeping that clip on there too. Try not to break the clip or use the clip because only 1 clip comes in that box with the 10 bags. The next section is on collecting specimens. Some places you work, per facility policy, you're going to be asked to collect specimens to send to the lab. Your role is to make sure that these are good specimens that aren't contaminated with other environmental things that we may think are going to grow, and then we think that the person's contaminated with it. So always label the specimen and put the lid on tight. Wear your gloves. But you cannot label your specimen until after it's been collected and put into the specimen container. So get your specimen, put it in the container, take off your gloves, wash your hands, and then label your specimen. Okay? Use clean technique. Try not to contaminate your specimen, and you're not supposed to put the specimen in a refrigerator where there's going to be any food. It has to go in a biohazard bag, and it has to go in a special refrigerator for specimens, which is usually in the soiled utility area. But make sure that you sealed it well, put it in your biohazard bag. You put your requisition or your sheets, paperwork in the front part of the bag where it's not zipped up. We'll go over that too in the clinical room with how to put it into the bag and then put the sheet or the paperwork on the outside of the bag. But make sure you have the tops on good so it doesn't spill out into the bag. A urinalysis. When we're using urine, we're using it to diagnose a problem with a urinary tract infection. We can also check diabetes people for their glucose levels with it. Okay? But it's clean technique. You're wearing your gloves. You're doing it the same way when you go give a lab specimen. They tell you to wipe yourself with this wipe, pee a little bit in the toilet, and catch a midstream sample. So if you can help the resident do that, that's what the instructions need to be. We're going to wipe first from front to back. You're going to pee a little bit and then stick the cup under there and catch a midstream sample. Then hand it back to you with your gloves on. Screw the lid on tight. Make sure you don't set the lid down on the counter or drop the lid on the floor and then pick the lid up and screw it onto their urine. Because now you have bacteria from whatever was on the floor. So open the sample container, pee in it, and close it, and don't contaminate anything. That's your clean catch urine. Okay? We take it with a little dipstick. Some places will let you do the dipstick. You have to get trained to know how. You just dip the dipstick in, blot it off a little bit, wait for 60 to 90 seconds, and then read it across the end of the container. We have some dipsticks in there. I'll show you how to do that. But you need to get checked off on that with wherever you work if they expect you to do those samples like that. Okay. If you're using a bedpan, you're going to ask the resident not to place the toilet tissue in the bedpan because you don't want to contaminate the urine that's in the bedpan with the toilet tissue. Okay. If you're using it from the collection port from the Foley catheter, this is what I was talking about earlier, right where the catheter comes into the bag tubing, right past the Y that you've taped onto their inner thigh, there's a specimen port. You're going to crimp off this clear tubing for about 20 to 30 minutes, and then you're going to come back with a syringe and draw your specimen out of the specimen port. Some places use needles, some places have special lure lock adapters that stick into that little rubber thing. Whatever your facility does, you need to get checked off on it first. But you are never going to get a specimen from this collection container, so don't get it from the bag. There's a little spout right here where you can get some out, but you really need to get it from the specimen port, not from this bag right here, on this part right here. Okay. Collecting your urine 24-hour specimen, we already talked about. You're going to have this labeled container with their name on it and a bucket of ice at their bedside, and every time they pee, they're going to put it in there. If they don't urinate in something that you can collect, if they accidentally wet their bed, if they go into the toilet, start the collection over. We need all 24 hours of urine in order to get an accurate reading from that collection sample. Some places have these stool sample specimen kits where they actually get just a teaspoon of stool, which is a little spatula full of the stool, and screw it in and send it to the lab. Screw the cap on tightly. Some places used to have these occult blood stools. They're looking for blood in the stool that you can't see with your eyes, but they have your little stick and spatula. They just want you to smear a little bit of stool in each one of these little boxes. It doesn't have to be a huge amount of stool and flowing out of the paper. It has to be able just a little smear on each box and then close it up, so that we can put some reagent on it to see if they check for occult blood. So just be cautious about how much stool you're putting in for a sample. We really only need about a teaspoon or tablespoon. From 2 different areas, use a blade, a tongue blade, a spatula, whatever you can to get it out of the collection specimen collection hat and into your collection cup. If you can get 2 different areas of the stool, preferably towards the center of the stool, and use clean technique to get the stool into the cup. That's all we need. They don't need the entire piece of stool. They don't need everything. Just some good samples from the center of the stool. 2 different areas. About a teaspoon. If you're doing a sputum sample, so for sputum, it's actually coming from their lungs. We don't want the spit that's from their mouth. For sputum, we're checking for tuberculosis or maybe for pneumonia, but we need some phlegm that's actually coming out of their lungs. The first thing you do for a sputum specimen is help them to rinse out their mouth to get the bacteria out of their mouth. So give them some water, rinse your mouth out, or brush their teeth and rinse their mouth out. Then have them take a deep breath in, open the cup, and spit directly, or hack it up directly into that cup. Okay, it goes straight into the specimen cup, screw on the lid, and then put it in the container, label it. Okay, you don't want just the spit or saliva from their mouth. If it looks all foamy and white, it's just spit from their mouth. That is not a sputum specimen. It's not an adequate sample. Throw that cup away and get another cup and try it again. Okay. Again, you're always trying to minimize your contamination. You're always wearing your gloves. You're always making sure that you know what kind of specimen you need and what it needs to be labeled with, and then sending it in a biohazard bag, storing it in a biohazard refrigerator until the lab comes to pick it up. And then just let the nurse know that you got the sample. Okay, so the collection hat will be in their toilet. There'll be a sign above that says, please collect the next 3 stools for occult blood. So every time they stool, we have to collect the stool and send it so we can check for blood. The feces, stool is called feces. So if a stool sample is going to contain feces. If the nurse asks for a sample of mucus, they're asking for the sputum from their lungs. So, and then urine is urine. But if they ask you for sputum, or if they ask you for a sample of mucus, they're actually asking for sputum. If they ask for a sample of feces, they're asking for some stool. And if you don't know, then you need to ask. When you're transferring the stool from the bedpan to the specimen container, you're using a wooden tongue blade or a plastic spatula or whatever the facility provides. And then with your 24-hour collection, it's always going to be chilled on ice. So if you have any questions about collecting specimens, collecting them correctly, make sure you follow your facility policy, make sure you ask your nurse for help, and then make sure we have a good sample to send off. All right. Elimination is important to maintain a healthy lifestyle for everyone. In your Mosby's book, if you could read the chapters 17, 18, and 21, it talks more about elimination. If you have any questions, just let me know.